this, and we are good to go. So take it away.
Okay, I'm Michael Moncure. I'm a physician at Truman Medical Center. I'm also the healthcare consultant that's associated with the Healthcare Coalition for Western Kansas and part of MARC. And we're going to basically take off from what we discussed last week. And we're going to be discussing, basically how to resources and documents that have been pushed wide and throughout the region that may be helpful in regards to if we ever find ourselves in a crisis situation in regards to healthcare resources. Last week we were able to discuss and we focused on two different things. One, the public health role of a crisis standard of care situation, and also how the Healthcare Coalition plays a part in that whole role. Heard from Erin Lynch, and she did an excellent job, and John Harlan, and basically defining what resources we have and what we need to be looking at if we are ever to hit this situation. And we were kind of reassured from the standpoint of what the role of the Healthcare Coalition was in trying to identify when the crisis might hit, because that's probably the most important thing, and to stay ahead of that. Today we're going to focus on more the institution's role in regards to crisis standards and pandemic response. And that probably has particular interest to a number of different individuals who play particular roles within hospitals and institutions within your jurisdiction. What you see in front of you, this slide shows two documents. One for the state of Missouri. The Missouri Hospital Association basically took a framework from Doug White and his group and a number of other organizations to look at what is most important when putting together a policy or guideline for your institution and how to respond to this particular pandemic situation, which has great fears. And we've seen a lot of news coverage of some of the coastal cities such as Seattle and New York, where they've actually had times where they've come dangerously close to running out of resources such as ICU beds, ventilators, and hospital care providers. That's on the left. On the right, you see guidelines for basically what's been instituted by the Kansas Health and Environmental Services. And these again are basically guidelines of how you can model your institution or your policies such to respond to that. And again, it's important to note that these are frameworks, and these are meant to basically hit all the different important issues that we know from an ethical standpoint we would have to hit and reassure a public that we're doing the right thing in the right time frame. Next slide. And so what I'm also going to show you is that the Healthcare Coalition and a number of different people throughout the state, particularly this MARC region, which encompasses the Kansas City metro area, looks at a lot of these things on a constant basis. And so crisis standards are not going to be invoked prior to us reaching that threshold. And in order to do that, in order to actually figure out when we're close to that, we've done a really good job. Institutions, jurisdictions, cities, and the entire region has basically worked together to make sure that information is present, such that we're tracking on a daily basis, the number of cases, the number of deaths, ventilators, the hospital beds, ICU beds. We've even sat down last week and we put together a model. There's an EM resource, basically a benchmark or a box format that is seen, and it's updated twice a day. Each hospital looks at what resources they have and are they open to actual COVID cases, such that they would have the PPE, the personnel, ICU beds, and ventilators, so that EMS is not sending someone to a situation where they may be at crisis standards and such that, and at some point that may be, if there was ever a pandemic that basically rushed the system and overwhelmed the healthcare system, that everyone's at crisis. So then we need to know that. One of the things that I talked about last week, using this IHME model in regards to projections of COVID-19 cases, there was something that was pretty alarming. As 2 weeks ago, this agency reported that in Missouri, the number of deaths were projected, and that was based on what their thoughts might be as far as our ability to remain compliant on stay-at-home standards, at 1,700 deaths. I'm originally from California, and that projection for California at the same time by August were 1,700 deaths. We're down to 438 now. And this is a fluid model because yesterday it was 385, but it really it really demonstrates how the public and policy and our ability to comply with that really affects, how this is, how these numbers are projected. The number of cases that are diagnosed on a daily basis, number of deaths that occur on a daily basis, and those models are then put forth. And so I think that's really important. Kansas has always done a really good job from the standpoint that they're projected at 200, they're projected at less deaths than Missouri. But again, there's still, and it's 318. But again, this demonstrates that the actions that we do from a public standpoint, as far as policy and everything, affects us all. And next slide. And this is just a granular model just showing of reporting data that's by the 40 hospitals within our region. And there are actually 34 that are actively reporting, that basically tells you how many cases, how many deaths have occurred in the different counties, how many numbers of hospitals are at critical shortage of PPE or some of the most important tools to actually protect our healthcare workers, as well as ventilators and ICU beds. So when you're able to see that there are a number of these institutions that are at a threshold or close to that, then we know that we're at crisis standards.
Michael, do you know whether any of the hospitals in the Kansas City metro area have been able to access some of these shortage resources that are in short supply through the federal stockpile?
As far as I know, and throughout the last couple of calls, healthcare coalition calls, there have been some institutions that have been able to reach into the stockpile to access some things. It's not been necessary to access ventilators because, as you can see, there are still over 300 ventilators that are available and present within the metro area. But PPE is probably the biggest concern, and I believe that there have been some N95 masks and such that have been divvied out. And again, that's the Healthcare Coalition, and Mark basically realizing and receiving reports from individual institutions and then trying to make sure that they're up to speed with what they need.
Thank you.
Okay. Hi, everyone. I'm Ryan Pferdehirt with the Center for Practical Bioethics, and I'm going to be moving through the slides, and Terry and Michael and John and Matthew will interject as we go through, and we'll have some open discussion, and we also appreciate questions, so chime in if there's anything that's not clear, but we have a framework that we're going to go through. This was a model based off an original document by Doug White at the University of Pittsburgh called Allocation of Scarce Critical Care Resources During a Public Health Emergency, and that has been kind of modified and changed a little bit to make it more applicable for the Missouri setting and also with COVID. So this document right now is Crisis Standards of Care for Scarce Resources During COVID-19 Pandemic, and we're going to go through this. This framework really helps on the idea of creating triage teams, and then how do we implement these. So next slide. One of the major things that we need to consider is there's 2 qualifications that need to be enacted before we talk about implementing this framework, and that is capacity needs to be overwhelmed or about to be overwhelmed for scarce resources. So this isn't something that you enact whenever you're having a rough day or a crisis in a moment. This has to be a systematic and really widespread attack. And also, it has to have a regional level authority declare an emergency. So both of those qualifying aspects have to be met. And when that happens, then we can move into this framework. But while we do shift that move into a different mindset, it's prioritizing a different ethical system rather than the normal. So crisis times call for crisis measures. It doesn't mean that the ethical principles go away. It's just we highlight different ones to greater importance. So the 5 principles that really ground this framework, because we want to make sure what we're doing is based off principles, is we still retain a duty to care. We have a duty to steward resources, distributive and procedural justice, reciprocity, and transparency. As we've talked before with the 4 principles of bioethics, of autonomy, beneficence, non-maleficence, and justice, when we have normal patient interactions, our goal is to uphold all 4 of those principles as high as possible. And a lot of ethical issues in the clinical setting come about when 1 or 2 or more of those principles are in conflict with each other. But a perfect patient situation sees all 4 of those upheld to the highest ability. What we're doing here is when we're shifting away, we're really focusing on the principles of justice, but then we also have additional principles that are going to come in. So the idea would be in a normal, good triage system, all 5 of these principles are also highlighted and held up to the highest ability. So while we do always will have a care, that is another thing I want to highlight about this framework is we will never not care for patients. We will never not provide what we can for patients to the max ability. What we're talking here is not a distribution of care, it's a distribution of scarce resources. So not every patient may be able to get the ventilator or the ICU bed that they need, but that does not mean that care and all efforts done for that patient that can be done are upheld as well. And we also have, we see this with organ procurement and distribution, scarce resources. When we have normal patient interaction in normal clinical settings, we don't really overly think scarce resources. We always think about funding and financial implications. Those have to be considered, and bed distribution. But whenever normal resources become scarce resources, now we have to think about how to be good stewards with that. We have to use these resources appropriately. It would be unethical to throw ventilators out the window and waste them where we could do good with those by applying them in the right situation. And this is just a modified version of that concept of applying the resources in the right ways to be the most effective as possible. But we also want transparency and reciprocity so that this is a fair process. And that is really the groundwork of this framework, is ensuring that these procedures and these decisions, which are going to have to be made in these crises, are done in the most fair way possible, that we are treating patients with justice and like patients are treated like, and we're using our resources appropriately and effectively, but also in a fair way. Next slide, please.
Before we move on, I want to go back to that. So when I think of reciprocity, Ryan, I think of golden rule, treat others the way you'd want to be treated. Is that what this is about, do you think?
I think this is treating people the way we should be treating them. It does come down to like a consequentialistic and a deontological argument of if you have an emergency and you have 100 patients coming to the emergency room immediately, you want to triage those patients to be able to do it in an effective way, and treating the most severe patients that need the help critically now, most urgently treating them. So you don't want to be spending time with scrapes and bruises where you have patients who need emergency medical treatment. So it's treating, I don't know if the golden rule would really be the most effective application of that, but it's more of a fairness application.
Yeah, maybe not in a utilitarian sort of mode. Yeah, I would want to think about that a bit more. And there's some blank space on the bottom of this slide, and maybe this is a place to say that this is all premised on another principle, which is that duty to prepare.
Mhm.
And so a lot of us have been spending, Dr. Moncure in particular, has been spending a lot of time in the last, 2 months or so on preparation for this potential of a crisis standard of care situation where we need to triage. And so now we didn't know where we would be when we scheduled this, but it's looking like we in the Kansas City area at least will not be triaging, will not be implementing these guidelines that we're going to be talking about today. So was that all for naught?
Absolutely not. I think
No, I don't think so, because much of what we've been working on for the last 2 months was also premised on preparations that were done, John, back in 2008, 2009, again in Kansas City with the Mid-America Regional Council and collaborators. Every hospital virtually was creating their guidelines for triage if H1N1 got out of hand or a previous SARS virus. So I think it is incumbent on us that we remember that all of these preparations are a duty, and that we are doing this, we're talking about this today in preparation for a time that may never come. But if it does come, we ought to be prepared. We have had time to prepare. And if we end up in that situation, perhaps in the fall, as the CDC director noted it 2 days ago, Dr. Redfield says it may be that we have a huge surge in the time when the normal flu season hits us, and the coronavirus comes back with a vengeance as well. We hope not, we pray not, but if we do, there's a lot of us that will be a lot better prepared than if it had hit us here 3 weeks ago, or maybe better prepared than what Seattle or New York City was.
Yeah, I think that the duty to prepare, which is on our website, really underscores the part of the issue I think that you're getting at, is that in 2009, we had a grand plan. It wasn't necessary to put into place. And it was elaborate in terms of how we would marshal resources across the country, how they'd march across the country along with the disease process, and a normal flu season kind of thing. That didn't happen this time. There was this explosion all at once, and we weren't prepared. And I think the duty to prepare that you underscore, that we really weren't in this country equally prepared to respond to, doesn't relieve us, and maybe that's your point here, doesn't relieve us of the duty to prepare again, which is very likely to happen come this fall. So this idea of preparing for the worst, which is really what we're doing in the crisis standards of care, really needs to be continue to be vigilant on that issue, because it's likely that we'll be in a similar situation moving forward, and we can't react next time nationwide in the way that we have the last 2 months or 3 months.
And another that's really come out of this that is of a benefit is it stresses the importance of having a good plan in place. We were lucky enough to be able to have time to develop frameworks and have these webinars even and discuss these ideas and ensure that we're putting these in a right situation and putting them in a fair way. But we also have to stress, what if we didn't have time? What if this hit and we're saying we're expecting something to maybe hit later in the fall? What if there's a new bug that comes out in 5 years and we don't have these enacted and it hits instantaneously? If we don't have plans and we're not prepared for that, we will not be able to effectively deliver care in an ethical manner.
Another principle that I think is missing, and these come, again, you said from documents that have been widely shared. But that is the I don't know if it's a duty so much as we need to have public trust and do everything with the public trust in mind. And one way that that has been accomplished is by community input. And so another duty that shows up in a lot of guideline duty to involve community members for community input. And one hospital that I'm working with, we've talked about that and haven't made much headway in involving anyone outside of that hospital. I don't know what others of you think about that, but is that important enough that we should add another bullet?
I think that falls under the transparency, where these decisions and these discussions of how do we enact this are not being made in the back room behind closed doors, but it's an open process. And I think the transparency of how these decisions are being enacted is just as important as the transparency of disclosing them when they're being enacted.
And that
community involvement should be involved in that, in terms of, if hospitals, I strongly believe that hospitals are a reflection of their communities, and they are members of the community, work in the hospitals and attend the hospitals. They should reflect the values and the principles of those communities as well. And the only way we can truly know the values and the principles of the communities that we serve is by having their buy-in and their involvement in the creation of these policies as well. I strongly disagree with a hospital putting in a policy that they feel is right, but isn't reflective of the morals and the values of the community that they serve.
One of the things that's stressed in at least a couple of the framework documents, particularly Doug White's, is you're right. Having community leaders be present when the policies invoke. A lot of times that may not. One of the things that I know of an institution I work with is going to try to make sure that the triage review committee that reviews the results of your triage, as well as that may look at appeal processes, they have individuals that can attest to the fairness of the process and be able to communicate that.
Thank you.
Yes. Next slide. So the first step, and really one of the most focal aspects of this, is the creation of a triage team. This would be the point team that helps to make these decisions. And one of the major aspects of this framework for the development of fairness is to take these decisions away from the bedside and away from the bedside attending physician. That allows, there's two types of rationing. There's systematic rationing, and then there's bedside rationing. Bedside rationing is almost universally seen as unethical, or less ethical than systematic rationing. That is where arbitrary decisions are happening in the moment, where we decide yes or no, does this patient, quote unquote, deserve this treatment. That allows a lot of implicit bias to come in, and also direct biases to come in, where if you have what is called systematic rationing, is what we're doing here, which is a policy discussion with community buy-in, with a lot of different hats at the table, being able to discuss this thoroughly, and then we apply it to all patients, treating all like patients as like, and it takes away the biases as much as possible. So taking this outside of the bedside into the policy framework allows for that to happen. So this, taking this decision away from the attending physician and moving it to a triage team allows for that to be a more systematic approach. And they are responsible for implementing the allocation framework, which we will describe later. And very important, as we just mentioned, the attending physician should not be making triage decisions. These decisions are based off public health ethics and not clinical ethics. And that's why it should move away from the clinical environment to some extent, but also that does not mean that the clinical ethics goes away. I think that it's just, what is the focus of the triage team? The triage team is focusing on the public health ethics, but the attending physician, while continuing to treat and care for those patients, should be still upholding the principles of clinical ethics. And this should be a team with expertise in allocation framework. And of the, as we're talking duty to prepare, this is one of the duties to prepare. We don't want to be in a crisis, creating a team and then having people who have not thought about these issues or been involved in these issues or have really an understanding of the framework that they would be expected to enact. This is an opportunity to be proactive in understanding of it, and then also having some familiarity so that these aren't new terms, these are not new ethical principles, and there's a good grasp of this before we're putting this into effect. And it's to enhance objectivity and avoid conflicts of commitments and minimize moral distress. Nobody really wants to enact crisis standards of care. Nobody's looking forward to it, and when these decisions come down, nobody's going to feel good about making a decision of who receives scarce resources. It's always going to be morally challenging to do that. But if you have a established objective framework put in place, you can at least rationalize through it that did this in the most right way possible for our understanding at this time. So that could help with the alleviation of moral distress and not feeling of personal conflicts and personal commitments impacting our ability to deliver our care in the most ethically and fair way possible. So the triage officers, which will be a part of the triage group, would be an appointed group with desirable qualities. You would want a physician who has expertise in management and triage, who has strong leadership abilities, and effective communication and conflict resolution skills. I think that all three of those recommendations go without saying, that if we are enacting these crisis standards of care and crisis resource allocation, we would want to be able to communicate the message of why we are doing this in an effective way and demonstrate strong leadership, because this is going to be coming down and these decisions will be made by the triage team. You want strong leadership within that triage team so that the rest of the hospital, patients, and the community feel comfortable with these decisions being made by people who are demonstrating expertise and ability to communicate that. And this triage team with officers will oversee all processes, access all patients. They will assign the level, and they will communicate with the attending physician directly over who receives the highest priority for scarce resources.
One of the things that we've been talking about at the hospital where I've been helping to create these guidelines is the need to have a team that with backup, so an alternate for every member. So multiple triage officers so that there's somebody available 24/7, but then a triage team reviewing, doing actually decision-making that has alternate members, not only so as to take the place of someone sick or unavailable for some other reason, but also because if these are physicians with some expertise in critical care, which some of them would be, they may well be attending some of the patients that are under consideration for triage, and then they would need to recuse themselves. So I think that's another important consideration when developing the triage teams, is having alternates.
And that may sound daunting to find this level of commitment, because this is going to be a very challenging and difficult task and time commitment. But with all the hospitals in the area that I've been working with, it's actually been fairly easy for them to find individuals, because I really feel everyone in the healthcare environment understands the severity of the moment we're in and put out the call. There's been a lot of people stepping up saying, what can I do? What more can I do? I just worked my shift, but I'm willing to volunteer to be on a triage team and help support however I can. So I don't really feel like it would be that challenging to find people willing to volunteer to help with this. Next, thank you. Then there should be, continuing with the triage, they should be nominated by chairs and directors of clinical departments. So you would want as much specialty and diverse of specialty as possible. I know infectious diseases physicians have been stepping up, and the attending physicians and hospitalists, but this should be as many specialties as possible to get as many voices at the table as possible. And the CMO emergency should have final approval of who's being recommended. And Then finally, there should be a single triage officer, chief triage officer. This is the point person who will generate the work assignments and identify potential sources of available officers. So this would be a person where the rest of the team can float around and you can have people on call. There's always one point person where it comes to assigning work, delegating tasks, really serves as a chief focal point of that triage team. In addition, there should be the more triage team. This can be, they will provide additional information for triage officers and help facilitate decision-making process. There's recommendations for a nurse with acute experience, administrative staff who can do information gathering. I know we've been talking with some hospitals about their health informatics, being able to take some of, we talk about the framework, taking scores and patients' critical conditions and having the EMRs generate them internally so that we can not necessarily like cut back on time in terms of gathering that information, but having informatics at the table was able to say, we can create that for you. We can help work with that. So having a lot of different people there, knowing the expertise of other people can really come together and help make this an effective way. And additional members, these are the framework that we're working off of from White says that these aren't necessarily have to be there, but they strongly recommend the additional involvement of ethics, chaplaincy, and social work. These are individuals who have a lot of experience, chaplaincy mostly, in my experience, of being able to sit down with patients, being able to come meet them where they are and work with them, and social workers as well, who do an amazing job of bonding with patients and providing resources and support for them throughout the process of their hospital stays.
And here too, a community member would be very valuable.
We've talked to some who have been talking about bringing on community faith leaders, a part of this team as well, and being able to discuss through where if you have particular patients of a particular religion, having their particular faith leader come and be able to communicate with them is very important as well.
I would think administrative staff are going to be very, very important to this team. We have talked about having de-identified patient data. So not getting into the electronic medical record, but having that data extracted minus gender or sexual identity, ethnicity, age, address, name, anything that could be identifying in a biasing sort of way. But collecting that and having that available on a daily basis for a team when there may be dozens or hundreds of patients to review, that seems a daunting task. I'm not exactly sure about implementation of that, but it also seems ethically appropriate.
And this framework also talks about taking this information every day in the beginning so that this could be a changing process so that patients who conditions may elevate or de-escalate, and depending on who needs the color code that we go into later, being able to pull that information every day is a very daunting task. Yes.
Mm-hmm.
Triage mechanism. This is the team will determine scores. They'll use the allocation framework to determine priority. And for patients being supported by scarce resources, evaluate them. As we just mentioned, it's a reassessment. They'll review a comprehensive list. And this protocol should be active once critical care resources, but not at any other given time. So there should be, for instance, there should be a surplus of ventilators, but not a surplus of ECMO. Guidelines will only apply for the shortage of the resource. So it's, if we're in a crisis standard, but our resources are okay for one particular resource, you want to be able to enact normal standards of care for that resource, but then you can enact this for other resources. And there should be an appeals process. This continues with the idea of transparency and fairness, but it also needs to be a very objective appeals process. We're creating a framework where we're taking this decision outside of the hands, essentially, of individual people and making this as purely rational as possible. But then you also want to allow for the human element. So they should be based on an objection of the overall framework. Should not be granted. It should be a reassessment of the process for that patient, rather than allowing additional qualifying information to go in. So as we start putting in additional variables, that would be creating biases and maybe emotional reactions and moral subjective judgments. You're trying to eliminate that as much as possible and make this as objective. Allowing for an appeals process where you can reintroduce that would be defeating the purpose of the framework. So it should be able to explain the grounds for the triage decision was made. Appeals based on considerations for other disagreement should be immediately brought to the review committee, and you can discuss having a separate triage review committee apart from the triage committee initially, so that a second pair of eyes could be judged to review these scores as well. Again, making this as fair as possible.
So 2 reasons to grant an appeal, I would think, would be an allegation that the framework has not been followed, that the protocol has not been followed. And secondly, that there's new information that needs to be considered. Can you think of any other reason to grant an appeal in a crisis standard of care?
Nothing really comes to mind.
I would agree with that.
And then we would have to say, because one of our principles early on was procedural justice, we would have to say that that is procedural justice. It may not feel like it is, because we grant a whole lot of appeals in normal times,
right,
under conventional standards. But this is different.
We are agreeing that this framework, if we go to crisis standards, that this framework should be implemented. The appeal would be saying that someone believes that the process wasn't followed properly, not that this person should receive care outside of that process.
One of the things that the ethics committee at one of the hospitals I worked with was insistent upon, and I think Ryan did a great job of identifying that both the individuals on the ethics committee, the chaplains, social work, and also our palliative care physicians, our palliative care healthcare worker team, have expertise in kind of communicating things, such that when there is an appeal that's brought forth and that decision is then handed back down to the family or whoever's objecting, whether it be the patient or the family, that be communicated by individuals that have good scripted language, that have a good ability to communicate to those individuals that this has been a fair process. It may not be agreeable. However, there was nothing within it that has an inherent bias that we perceive in creating the policy.
Nathan.
We'll get into this later, but it's also, as Michael just said, the communication, I think, is very important of this. One of the, I know Matthew works with ethical AI, and I always believe that one of the reasons why I don't think AI is going to replace every doctor is because patients don't really want to hear that a number was pulled through an algorithm and that number was low enough, and they're just going off that number. That might be how we're doing this, but that doesn't mean that's how it should be communicated to the family. And conveying that with empathy and humanity is incredibly important, I believe. And I think palliative medicine does a great job of conveying that type of information of where we are clinically, but then also how we're going to continue to support those patients emotionally and spiritually.
Mm-hmm. Yeah, just noting on this in the chat that Nathan has noted that appeals should also be available if there's a dispute about the underlying facts. So there could be new information or some of the information that a decision was made on was inaccurate, and that's a good point.
Yeah.
Thank you.
So section 2 is the process. It's a two-step process. First, you calculate each patient's primary score based off multiple principal allocation framework, and then determining each day how that priority will groups will receive access to the critical interventions. So the ethical framework, this is a utilitarianistic perspective of the goal is to maximize benefits for populations of patients. And this is often expressed as the greatest number of good for the greatest good for the greatest amount of people, greatest number of people. So that is what we're attempting to do with this, is providing the most amount of good that is possible for the most amount of people. So this starts off with a point system, and it's for SOMA scores. Could Michael maybe talk more about this in terms of the value of SOFA scores?
Again, in trying to make sure that what we're doing is extremely objective, and this is a score that's made up basically to determine sepsis severity, and it's been well validated from that standpoint. Now, basically, what it entails is what a Glasgow Coma scale looks like on a particular day for a patient. It looks at their renal function, because patients, particularly with COVID, that have deteriorating renal function and require dialysis or measures of renal replacement, do poorly. It takes into account a couple of other lab parameters, and so basically, one of the hospitals, if you have an EMR, there's a way for that stuff to feed into a system and really correct or calculate that on a daily basis. But that's been shown when there's been a worsening of that score, that patients do poorly in the face of sepsis. And this is one of the parameters that is just like you point out in the University of Pittsburgh model or framework, they really rely heavily on, and it's been adopted a lot of places. And
as the main point of all that is also, as Terry had said in an interview I heard him do a couple of days ago, is we want to make sure these are as clinically relevant decisions as possible, rather than socioeconomic or personal or individualized decisions. We don't want to be thinking who that patient is personally versus who gets it, another patient personally, but more so this is as clinical of a decision as possible, of trying to make every patient with this score as equal as possible.
So we got a request from Chris that says, do you want to speculate on strategies for triage team to respond to requests for what we might simply call mercy, which may be a prime concern?
Who wants to speculate? I think that's, we go back to what you just said, Ryan, is that the point of a point system is to try to, as accurately as possible, determine who survivability.
Mm-hmm.
And mercy goes into the care that the care providers are offering every second, every minute that they are in that ICU room, attending to the patient. But to respond to an appeal for mercy from probably the loved ones of one patient over against another, then moves us away from that hopefully objective clinical criteria aimed at assessing who is most likely to survive. So I think that's exactly what one would not want to do, other than to respond to appeals for mercy with compassion and understanding of why, of course, you would want us to treat your loved one specially, because he is special to you, they are special to you. But so is the next person, or they ought to be. And that's the tragedy of crisis standards of care and overwhelming hospital systems. That's why we try to stay home and distance so as not to get there.
I would completely agree. And one of the things that John and I talked about in preparation for the earlier meeting last week, is that I have a friend who's in the state of Georgia, and they've gotten a lot of publicity lately. And the governor there is really against and has made it very clear that he's against removing or making someone comfort care based on futility unless the family is in agreement. And he's not really willing to budge even in a crisis situation. Now, one of the things that we are hanging our hats on in crisis situations that we as healthcare providers are protected if we were to make a decision. But can you imagine a situation where all the ventilators in your institution and within the region are used up, and you've got someone who's undergoing care that is deemed futile by ethics and the healthcare professionals at the bedside that were evaluating that situation. However, they don't feel like they can insist upon that and provide them comfort care, and they have some patient who could easily survive given no short course of critical care on a ventilator or such that would be the means at which someone may succumb.
And these are also extreme circumstances for implementing this, but they're not necessarily extreme things that we do. An ethics committee we're discussing, they knew a patient who was going in for cardiothoracic surgery that was necessary, and they put in the patient's clinical indicators, age, expectations, and the algorithm said that they don't expect this surgery to be beneficial for this patient, and therefore the surgeon said, I'm not recommending this and I will not do this surgery. And the family felt comforted by that. They didn't feel like, are we not doing enough? It was a feeling of, no, this is not going to have a benefit for this patient. It could be something, but it's not something that is necessarily going to bring the outcome that we're looking for. So they would deem it to some extent, I mean, I don't like using the term futile, but to some extent, this will not have the benefit that this patient is looking for, and it will not improve the quality of life that this patient is looking for. Therefore, we're not recommending it. And in a normal time, that should be the focus of our allocation of time and resources is, are we going to have a benefit for this patient? And that should be reassessed for every procedure that we ever do for patients. Is when we're in crisis standards of care, is should this be for this patient because we could be helping another patient? And we don't really want to be thinking about another patient when we're determining what's in this patient's best interest. And that's where crisis standards of care come in, is now we're working with scarce resources that we have to consider that other patient. And that's where the challenge comes in.
But we do all of the time in conventional times as well. And it's in our allocation of scarce solid organs for transplant.
Right.
So I serve on a committee that in conventional times meets every week to look at potential recipients of a heart or a ventricular assist device. And these mechanisms, scoring mechanisms, are very familiar because there too, it's who will likely benefit the most, or for whom will this therapy be most effective versus ineffective. It'll work or it won't work. And there are scoring mechanisms there too. There are criteria that need to be met. Do some patients and families ask for special consideration for mercy? Certainly. But if we do it on that basis versus some objective criteria that's clinical in nature, assessing effectiveness or not, then we're being unfair. It's not procedural justice.
This is why this is such a challenging topic, is it's applying scarce resource ethics to resources that are typically not scarce. So we're coming from that previous mentality of most patients who need a ventilator are able to receive it, but now ventilators become a scarce resource. Now we're applying transplant ethics to typical standards of care, which makes this a more ethically challenging situation.
And I'm curious too whether or not Nathan's question and Chris's question are two sides of the same coin. That the person who is asking for mercy doesn't feel that there's additional underlying facts that need to be brought to bear on this case, which may not be perfectly evident to the people making the decision.
If you knew my mama like I know her, you know, if you could understand what it would be like for me to live without my partner, yeah, there's more to be learned. And we should listen, and we should care, and we should be compassionate, and we should be fair.
So something occurred to me in this sort of comparison to organ transplantation and procurement, in that one of the concerns cited earlier is that we make these plans and for crisis standards of care and are often sort of making them hoping to never need them, right? And a lot of the people who are involved in making these plans, like it is likely that they've never found themselves in a circumstance of needing something like this. Does it make sense to incorporate people who have specifically worked on something like organ transplantation and procurement as part of sort of like a source of expert advice, right? Someone who has actually engaged very specifically with the question of allocation of scarce resources, like as a day-to-day practice, and then it seems like talking to them and incorporating them in a conversation about setting up a crisis standards plan would make a lot of sense, because if there's issues that are going to come up that you're not going to think of, they may, right?
Yeah, that's been true with Zeke Emanuel and Art Kaplan and Joe Finns. They've all been very outspoken around it, that they really felt that much of the questions that they faced in their work in transplant issues have really informed a lot of their judgments about how to proceed in this arena and over and over again. And Zeke has even said in many of the community settings where he's tried to gather community input, he uses transplant examples as a way for people to think about it when we're not in a crisis situation, because it makes more sense to them and they understand it more easily than we would in a crisis situation.
Why don't you move to the next slide, Matthew, because I do want to say one other thing about scoring mechanisms. That one, and then maybe one more, the comorbidities. The hospital where I've been helping on guidelines is tweaking this, using this document from Pittsburgh and other places like St. Louis, but then tweaking the scoring mechanism to add functional status or frailty indices as another significant indicator of survivability or mortality. And I'm wondering if you have some thoughts about that, Dr. Moncure.
You know, frailty, I'm a trauma surgeon by training, general surgeon, and everything I've ever looked at in regards to frailty has demonstrated some correlation to outcomes, or someone's ability to get through an operation and be discharged and get home versus requiring a lot of resources after or succumbing to that, and as well as a severe trauma. And that holds true for a lot of critical care illnesses. So there is some bearing that frailty could be a pretty good indicator, because if you come into this and you're say elderly, you have a lot of comorbid diseases and you're bedridden, then it's going to make it very difficult for you to get through a stint where you are further ill and have to get through an illness and then try to recover from that. So there could be some warrant to that.
And I think a criticism that's warranted of these scoring mechanisms is that it's though the aim is to be objective as possible, it's scored. And we all know that apples and oranges and bananas and grapefruits all weigh differently. So comorbidities, for example, or different levels of frailty and ability to for daily living, ADLs, versus SOFA scores. How do we weight each of those and do so accurately? What counts more than something else? So do we end up with a inequitable scoring system anyway? And then the other challenge is nobody really has implemented this, or not sufficiently so as to have good data to know how well it works. So there's some problems with this too. We're just all trying to do the best we can.
I think one thing that we always have to keep in perspective is no matter what tools we create and procedures we make, they're made by humans. So they're going to have some imperfections about them. We cannot create the perfect system. There's always going to be something that's going to fall through the cracks. And that's another thing is this is a live document, and we would also encourage if hospital systems were thinking about adopting this to be able to make it applicable to their situation. I know a couple hospitals that I've been working with have taken off some of these comorbidities and added other ones that they felt are important, and based off their surgeons and their attendings who put in recommendations. So being able to have this framework not be a square peg going into a round hole, but actually making it fit within the hospital that it's being enacted in.
We're just about at time, aren't we, Matthew?
Yeah, we're coming up on our time. Is there anything in the kind of towards the end of here that we want to make sure that we get to before we sign off?
Tiebreakers, I think, would be
Okay.
one I want to discuss on.
And actually, Nathan also brings up the issue of underlying health inequities. The fact that social determinants of health impact greatly the patients that we get in the hospital in crisis times as well as conventional, and also the allegations that some of these guidelines that maybe especially that focus on functional status prior to entering the hospital, 30 days prior, could be inequitable, that it would lead to discrimination against those with disabilities. So awareness of those possibilities and awareness of the realities of underlying systemic injustice that impacts the patients we get and the outcomes that we anticipate is something that needs to be discussed a lot longer than 30 seconds.
This is
You know,
something.
I would suggest that be a completely separate.
That's not a side note.
But this is not an easy issue. That's a whole another hour. Yeah.
I think there's something really interesting to be said about, like, we've kind of deployed the word and the idea of objectivity several times, and Nathan's point here about how underlying systemic inequities can be sort of magnified by SOFA scores, and so this thing that we're sort of thinking of as being like an objective
solution
has this potential to sort of magnify these kind of like political or allocation based issues that are already kind of endemic to our society, right? So like we think this thing is like neutral because it's objective, and it turns out it's actually quite the opposite.
Yeah, it's using variables to determine a final score, but those variables are determined by larger systematic injustices within the society.
And this is why it's extremely important that I've been very happy that all the discussions that I've set forth in the institution I work at have been privy with the ethics committee and individuals such as everyone on this panel who have expertise in that can think about some things that we as clinicians, sometimes we are thinking, round hole, round peg, square hole, square peg, and we don't often kind of take into consideration other things that could factor or make this unfair.
And for anyone who cares, if you were to email me and I'll volunteer Matthew here, happy to send out this slide deck to anyone since we weren't able to get through a majority of it.
Of course. Yep. the slides, as usual, the slides for these presentations are always available at request. And if there's any other resources or anything that we mentioned in here that you are having some trouble finding, you're able to email me at mpiecha@practicalbioethics.org. I'll just drop that in the chat as well in case people need it.
I think John's point earlier, as far as preparing for the worst, is always the better part of valor. If you look at the states that have really, really prepared for the worst and have gone all in, such as California, you look at countries such as South Korea, these countries and these states have really kind of pushed the envelope and before it became a disaster. And they've been able to kind of stave off the numbers. They've prepared for the worst. They're now shipping ventilators and equipment to other countries. But being early, being aggressive, and being logical and scientific in their methodology has helped.
An adage in palliative medicine that I learned during my education was hope for the best, prepare for the worst. So when we're talking to patients, we'll outline what we're expecting, but just because that's what expectations are doesn't mean that you are not hoping for change. We've all seen situations change, so you can always have hope, but you also have to stay realistic in your preparations of how bad could it be.
All right, and with that, unless anyone else has a final comment, I'd like to, with respect to everyone's time, probably wrap this up. Just a reminder, these webinars are all recorded and we post them to our YouTube channel. So if you want to review any of the content here or share this with your colleagues, you can find it on YouTube. Just search Practical Bioethics and you'll be able to find it from there. We have this series is ongoing, and next week we will start a two-part webinar on advanced care planning and shared medical decision making amid pandemic conditions, and that will involve some of the center staff, my colleagues, and some other speakers. So you can go to practicalbioethics.org and find the schedule for those on the pandemic resources page. And if any other
Yeah, Matthew, that's particularly focused on long-term care.
Yeah, okay, so particularly focused toward long-term care for that, and the sort of special requirements that they have. So with that, I'd just like to thank everyone for being on and thank our speakers, especially Dr. Moncure, for making time to be with us today. And to everyone else, we hope to see you next week.
Thank you.
All right, you have a
Thank
good
you.
Thank you.
Thank you.